Hello, everyone, and welcome to our 2023 Self-Direction Virtual Conference Series. My name is Merle Edwards-Orr. I'm a Senior Advisor at Applied Self-Direction, and thank you very much for joining us today. I want to do, for our session, just to make sure that we're here at the right session, the Veteran-Directed Care, Expansion, and Federal Updates. I'm going to run through a couple of quick housekeeping issues before we begin. Your microphone has been automatically muted, and due to the volume of attendees, please remain muted. You can submit your questions and comments at any time during the session using the Q&A pod in the lower left-hand corner of the Adobe room. We have reserved time at the end of the session for your questions. All questions and comments will remain anonymous. The session is being recorded and will be available on our website. Closed captions for the entire conference series is available courtesy of our sponsor, Avero. You can access the closed captions by clicking CC icon at the top of the Adobe room. I'm thrilled to introduce our speakers for today. We have Dan Sheps, who is the Director of Purchased Long-Term Care Policy of the Policy Group in the Office of Geriatric Extended Care at the U.S. Department of Veterans Affairs. He is the National Program Officer for all long-term care services purchased by the VA, including the Veteran-Directed Care Program. Pat Brady is the Vice President and joined the Lewin Group in 2011. Prior to the Lewin Group, Pat worked for the Veterans Health Administration for 8 years. Since 2008, Pat has supported both VHA and the Administration of Community Living with growing and improving VDC. So with that, and with no further ado, I think I will turn it over to Pat.
Thank you, Merle. Hello, everyone. It's such a pleasure to be here and to see all of our attendees, many names who I recognize. Also, just want to take a moment to thank Merle, Casey, and the rest of Applied Self-Direction for having us here to talk about veteran-directed care, which we're so grateful to have the support of all of ASD participants, those of you that operate veteran-directed care and continue to provide critical services in support of an innovative LTSS program for veterans, and those of you who are interested in breaking into this area. We're going to talk through 3 things today. We're going to start with an overview, tell you a little bit about what the program is, how it's offered, a little bit about where we're going with the program and what we know about it to date. For many of you that know this program, there are likely going to be tidbits of information that maybe you didn't know, but we're also going to take a moment just to talk about the program at a high level. We're going to talk about some efforts jointly with VA and the Administration for Community Living to move towards continual standardization so that veterans accessing this program, whether they're in Togus or Seattle or Tampa or San Diego, receive similar services and supports to help them remain at home. Also recognizing that there are opportunities to make sure that we're providing guidance and support to VDC programs. And when I say VDC programs, talking about VA medical centers operating veteran-directed care, as well as VDC providers and their FMS partners on that. So we'll talk through some opportunities for standardization. And then we'll finish with some critical updates and recent legislation impacting veterans, which has to do with veteran-directed care, but is an important consideration for we interact with veterans every day. And there are some important updates and legislative initiatives that increase access, services, eligibility, and having an awareness of those is really important as we interface with veterans every day. So I will turn it over to Dan to hit on our first agenda item.
Thank you, Patrick. And
Dan, cannot hear you yet.
How about now? Patrick? Uh-oh.
Yep, I'm hearing you, Dan.
Dan, I can confirm once
good.
I do hear you.
Well,
Merle, let me make sure you can hear me.
Yes, Patrick, I can hear you.
Yeah, I think we're good.
Okay,
Okay,
and
good.
thank you. I joined Patrick and thank you, and welcome your attendance today and thanking you for your work with veterans. And it's great to join three wonderful colleagues, Patrick Brady, Merle Edwards-Orr, and Casey DeLuca. So we're very happy to be here today. I wanted to go over a few basics about veteran-directed and where we've moved since the last time we've met with all of you. Just as a reminder, this program focuses on veterans of any age who are at high risk, often high risk, of admission to a nursing home. In its VA's model of self-directed care, veterans hire workers, including family, friends, and neighbors, to provide personal care services. This is done in accordance with a plan that the veteran develops, assisted by a counselor, and VA approves those plans. Veterans receive assistance to manage their responsibilities from these person-centered counselors, as well as the financial management service that so critically supports veteran-directed care. VA medical centers do not operate these programs themselves. We purchase these services from VA-approved aging and disability network agencies, and we do this through a mechanism that's available to us through the Mission Act called Veteran Care Agreements. The components of the program really start with our personal care services case mix tool score. We use a version of MIN choices and a couple of questions from MDS 2.0, and a score is developed between letters A through K, with the addition of a case mix V for ventilator care at the very top end. The case mix level assignment links to a budget amount, and this is by county for each case mix level. We have a copy of this on our SharePoint, but more importantly, publicly, it's available on the ACL SharePoint or the ACL website. So the VDC provider works with the veteran after they work through the person-centered planning, and that the outcome of that is a spending plan, and that again is approved by the VA Medical Center. VA purchases care and goods that are identified in the veteran spending plan. It's important to understand, I think, as well, that items have to be in that spending plan, or we don't have the authority to pay for them. So that's like a key part, we're very much spending plan based. Veterans spend, as it turns out, about 97% of their available budgets on direct care, labor, or labor-related costs. We're also purchasing administrative services from the VDC providers. Spending is monitored on a monthly basis. We know that the FMS and the ADNA look at spending, and our coordinators do as well. When veterans opt into veteran-directed care, they opt out of our agency-based homemaker home health aid program, adult day health care, and home respite services. Now, this does not mean that they, in an emergency, they can't use, or as a plan, they can't use an agency if they don't have a second self-hire worker employee to support them, or for planned respite. That's fine. They purchase that service through their veteran-directed care budget, but we're not talking about a separate authorization, a separate VA payment for those services through eligibility for that program. Okay, there are 4 types of providers that we purchase services from using these veteran care agreements. Area agencies on aging, Aging and Disability Resource Center, No Wrong Door, Centers for Independent Living, and state units on aging. Before we offer a VCA, ADNAs need to complete a readiness review, which we conduct. And this ensures that, the ADNA has the wherewithal, the skills and competencies to deliver VDC to veterans. And that's a 2-part readiness review, one on the programmatic side and then one on the financial management side. So the program has grown a bit with the pandemic, and that growth continues post-pandemic, and it continues now into fiscal year 2023, which began in October. We're growing at over 20% a year fairly consistently. The actuaries sat us down last fall and said, we're going to pull veteran-directed out of how we model personal care services, out of the standard model, because you're just growing so rapidly that we need to project this differently than we would project growth in a mature program. So that was like a sign that, like, even the actuaries are paying attention. These are our largest programs: San Antonio, Richmond, St. Louis, Denver, Montana, and Salt Lake. I think our average size of the program is up to 90 now, and 21 medical centers. We have 70 medical centers that have the program, and 21 of them have over 100 veterans, or had over 100 veterans on their rolls last year in fiscal 22. So who are these veterans and veteran-directed? They are generally younger than veterans that we see in our other programs. A full 50% of them are under age 75, which is actually quite remarkable. More of them are service-connected. A third of them are in the highest priority group in terms of eligibility. They tend to be more rural. Our programs in rural areas are very strong. We have particularly good research data on the effectiveness of this program in rural areas. Our rural area programs, many of them operate a little differently than our more metropolitan programs, because in many of those rural areas, we're basically serving the function of a home health agency. So we're broader in who we're admitting to the program. We're really admitting all levels of care, and that's a little different than some of our more urban programs, which really focus on the highest level disabilities. Those high case mixes where veterans need assistance in 6 or 7 of the 8 ADLs that we measure in that case mix tool. On average, average veteran receives 50 hours of care per week. This is a population for one reason or another can have designated an authorized representative, and the average hourly wage for workers is $18.31. And these are new statistics here on average hours and wages. I will now turn it over to Patrick to talk about standardization.
Thank you, Dan. There's a lot of focus and emphasis, I mentioned this early, on how can we support VDC programs, both medical centers as well as VDC providers, with ongoing quality improvement and standardization in the program. At the end of the day, the goal here is for every minute that we spend, maximize that amount of time that can be spent on direct veteran care, helping keep that individual at home, supporting them, their family members, their caregivers, their workers. The best way to do that is to promote standardization and, to the greatest extent possible, the efficiencies that come along with that. On one side, we have the VDC Field Guidebook. This is an internal VA document that Dan's going to speak through that aims to standardize how medical centers should manage, operate veteran-directed care, so targeted to that VA audience. ACL last month held an educational webinar on the ACL VDC Operations Manual, which defines VA's requirements for the program, as well as some promising and best practices. And then if you have not been there before, ACL offers a wealth of resources and information and tools that can help continuous quality improvement in veteran-directed care. We're going to summarize and highlight all of these opportunities for program standardization. Dan, why don't we start by spending a little bit of time talking about the Field Guidebook?
Sure, Patrick. And publication dates are likely to slip into the first week in April, but be that as it may. Excuse me for just a minute. There we are. This field guidebook, a procedures document is what it is really. It's been under construction for a good long time. And we never quite had the mechanism or the platform for it until the last year or so. And so we're covering a great many items in this document. Eligibility, what is when do we duplicate services, or what is it, what defines duplication, what services can we not, we can't duplicate. For veterans who at very high needs, primarily ventilator care veterans, we need to be mindful of the 65% rule, which actually limits annual per veteran spending for purchased home and community-based services. We have a section on provider standards, various process flows, a lot of internal documents. Unable to schedule is our term for wait list. The case mix tool we've talked about earlier on. Case mix V and inpatient hospital support. This is different. This is a change in our procedure. Up to now with ventilator cases, we've just automatically gone to the amount, the budget amount that is allowed under case mix V. We've taken a step back from that, and we want the counselor to work with the veteran to build the budget up from case mix K to meet their needs, as opposed to start at case mix V and build a budget. Start with K and build a budget forward. The other change we've made is in certain cases, we are going to allow VDC employees to support the veteran while the veteran is an inpatient in hospital. There are certain cases that we're going to allow that. VDC budgets and spending, that's really a high-level overview. These are more on the right side now, more items that are internal, billing and reimbursement. That's just for our staff to be conversant with that. It's not the heavy lift that you have with the with the ACL billing guide. The VDC refund policy is important. There are times when we need to when the agency receives a refund check from IRS, perhaps from workers' compensation, and we've not been very good or willing necessarily to take that money back. It is VA funds. This lays out the policy for that. There are kind of new standards for our staff regarding care coordination and oversight. This implements recommendations from the audit by the Inspector General of the program. Now, a couple years back, it was generally we did very well, and the AD&As, the report, the IG report on their work was stellar. I mean, no one gets positive remarks from the Inspector General audit, but AD&A providers managed to do it, which made us very glad. All of our all of our procedure guides have new information now on disruptions to the provision of care, veterans who are being disruptive, and different approaches, different interventions to work with those veterans. There's safety, and then roles and responsibilities. That's really role and responsibility of our VDC coordinators. This document is 15 pages long. There are certain of these items that are actually linked to other sections, but I think those are the highlights and comprehensive for us. So, Patrick, back to you.
Thank you, Dan. Now we'll spend just a little bit of time talking about the operations manual. I'm not going to spend too much time, and we will tell you why in just a bit, but I'm going to hit on some of the highest level critical factors. We're going to spend a little bit of time just talking about how this is organized. Again, this is really informed by VA's expectations and what we know are some promising best practices in terms of implementing and operating the program. There are several, I think there's 7 key operational areas. There's background, referral and intake, assessment and spending plan, initiating services and hiring workers, ongoing monitoring, billing and invoicing, and then finally, quality. It is available online. So you'll see a quick snapshot here of the overview. If you draw your eyes to the middle of the screen, you'll see that there are breakdowns between VA requirements, things that every VDC provider has to do based on VA's expectations. And then on the right-hand side of that box, you'll see some best practices, some standard operating procedures based on what we know from VDC providers, including FMSs, operating this program. We've tried to really pull forward those best practices. Again, it's available online. There's also a training on the operations manual, which we're going to provide some links in just a little bit. This is not a test of everyone's eyesight. This is just a screenshot so you can see how this is organized. So this is an appendix with hyperlinks. So the 7 sections are here. You'll see that there's some sub-bullets with specific content underneath each of these sections. You can click on it and it'll actually take you directly to that section. It's organized that way so that you can find information quickly, easily for your program. I'm going to hit on just a couple, just so you can get a sense of the type of information, the level of detail that's in the operations manual. One of the sections, assessment and spending plan develop. I did specifically pull this one out intentionally. There's another slide after that, but let's talk through this. So providers are expected to conduct an initial assessment, reassessment, work with the veteran to develop service plans annually, in the first year, that's semi-annually, or when there is a new service authorization. So it's pretty clear, the expectations around how and when assessments are conducted. And then there's a little bit more information on how to do this in a person-centered way. There's such an emphasis on trying to adhere to some of the principles of self-direction that ASD, Kevin Mahoney, a lot of people spend so much time and effort really making sure that this is a person individualized spending plan and care plan for this program. Tools that you can use during the assessment process, and then timeframes. So if you get a referral, when do you actually need to make contact with the veteran? When do you need to go into the home to connect this initial assessment? When do you need to submit documentation to the medical center? I pulled this out. These slides come from ACL's training last month, so I've repurposed them here. What I did want to say about this is that to the greatest extent possible, VA does want to create templates, and ACL wants to create templates that support VDC providers with adhering to requirements, operating the program efficiently and effectively. So there are some tools at your disposal. The two that I'm going to call out here, the monthly spending plan template. It's really helpful because it does break down to the level of detail the requirements that VA wants and needs to see in a spending plan. How do services tie to individualized goals? Who are the workers for the veteran? What's their routine schedule? What types of personal care services are they providing to the veteran? How does all that spending come out to average monthly spending? Are veterans going to stay within their global budgets? I know I'm tossing around a lot of VDC terms and terminology. If you're not familiar with them, they're defined in some of these resources. But what I want to say is that by providing these tools like the spending plan template, the second hyperlinked that you'll see here is the monthly service report. These are tools that you can adapt locally. You'll know that they'll meet the needs of the VA. It doesn't mean that you cannot customize them further. It doesn't mean that you cannot use your own templates and services. But these resources are going to tell you exactly what you need to do to adhere to VA's requirements and provide a lens into some promising practices around the country. Here we have just a quick overview on initiating services and hiring workers. There are a lot of questions about this that we get from VDC coordinators on the VA side. There's specific information around requirements for employees and authorized representatives. There's some documentation around pay rates and how that needs to be approached. There's some really important regulations that are not VA regulations. They're Department of Labor, other federal and state regulations governing how individuals establish pay rates and how we need to support veterans with those decisions. Background checks is one that comes up a lot, as well as the use of home care agencies when veterans may be challenged to find a self-directed worker, maybe when there's a transition between self-directed workers, when and to what extent and how can veterans use agency services. I said this at the beginning, the No Wrong Door website contains a wealth of information. The Operations Manual is hyperlinked here. It's a part of the No Wrong Door VDC website. There was an educational webinar last month. Again, that was recorded. The slides are there. The billing guide, some of those templates. So if you're operating veteran-directed care, if you're interested in veteran-directed care, bookmark that website, go to it. If you ever have any questions about the website, things that are there, if you have questions about veteran-directed care, ACL has a mailbox. It's at the bottom, veteran-directed@acl.hhs.gov. All of these are resources to, again, support VDC programs, including VDC providers, with delivering veteran-directed care in support of veterans. Shifting gears. I'm going to spend I think it's going to be about 10 minutes. Depends how long-winded I go and how long-winded I am. But recent legislation, it's been a pretty active year in terms of VA legislation. I want to caveat this by saying I'm not representing the VA in talking about this recent legislation and what it means for the VA and for veterans. That is not the case. I'm not representing VA here. Number two, I'm not the expert on any one pieces of these legislation. But what I do know is I encounter veterans every single day, as do you. Having some insight, awareness about these pieces of legislation, what it means for veterans, it gives me the opportunity to have those conversations that are critically important to making sure veterans maximize use of the services and benefits they've earned through their military service. I'm going to put that one other way. There's about 18 to 19 million living veterans. About half of them are enrolled in VA healthcare. Only about a third of them use VA healthcare in a given year. So VA has this expansive, comprehensive, sophisticated, veteran-centric healthcare system. It serves millions of veterans, but there are a lot of veterans who are not tapped into the VA as well. So when we encounter veterans, just being able to talk at least at a high level really positions us to deliver some value in helping veterans to connect to care. And we'll start first with the PACT Act. It was passed last summer. It was in the news. was reference to supporting veterans with exposure to toxic burn pits. The full name of that law is the Sergeant First Class Health Robinson Promise to Address Comprehensive Toxics, the PACT Act. It's a long term, most commonly referred to as the PACT Act. It's one of the largest pieces of legislation in terms of expanding eligibility of VA healthcare to veterans. I believe the figure quoted is about 3.5 million veterans with new eligibility for VA healthcare as a result of exposure to toxic burn pits, hitting multiple service eras. There's 23 presumptive conditions. Presumptive is a really important term that's used within the VA for eligibility. Essentially, it means if you are a veteran, if you meet certain criteria, such as when and where you served, having a condition is presumed to be connected to your military service, meaning it's not directly attributed, but there's a presumed connection. So it's a presumed condition. So there's 23 new conditions that expand eligibility for those individuals. And again, 3.5 million veterans. The VA has a lot of resources, so I've hyperlinked them here. You'll see them in the slide deck. There's a great slide deck, all things PACT Act 101. There's a website about the PACT Act and benefits. The Bob Woodruff Foundation is actually hosting a PACT Act educational webinar in partnership with Iraq and Afghanistan Veterans of America in just a couple weeks on 4/5. So several resources that you can bookmark, you can flag, you can read through. When you work with veterans, ask them if they are aware of this law, what it could mean for them. VA is going to offer screenings. There may be some veterans that need to schedule a screening, but it's really important here due to this increased eligibility that veterans are able to assess whether or not there are any, if they are impacted, and if so, how. The second piece of legislation, the Compact Act of 2020, starting 2 months ago, January 7th, 2023, veterans in acute suicidal crisis can receive immediate care, could be at a VA, it could be in the community for free. It includes 30 days of inpatient, outpatient care up to 90 days. What's critical about this is eligibility does not depend on enrollment status. Almost all of VA care, with a couple exceptions, have to be pre-authorized, and you have to be enrolled in VA to receive that health care. That is not true for this new mental health, behavioral health to address suicidal crisis. You do not need to be enrolled at VA. Being a veteran with some other requirements will allow you to receive that care in the community or at the VA at no cost. One of VA's most important priorities and goals, and it's not just VA's, it's the White House's, it's the CDC, is to address suicide prevention for veterans. Suicide as a whole is a public health crisis, and it's even more so for veterans and service members. So this is a really important piece of information so that veterans going through crisis can get care at the right place at the right time. We have some information here for you, a press release, the legislation, the VA suicide prevention website, which will talk about the Compact Act. It'll talk about other initiatives, priorities, programs that are available to veterans, including, I thought, a really great one last year, which expanded access of the Veteran Crisis Line to 988 and then 1. So when individuals call the suicide hotline 988, they can press 1 and it takes them to the Veterans Crisis Line. So the Veterans Crisis Line still has a toll-free number, but we're now increasing access to the VCL in a new and innovative way. So familiarize yourself with suicide prevention efforts. Make sure that we're engaging with veterans about potential behavioral health, mental health needs. And the VA is here and has a goal to reduce veteran suicide and a wealth of services and supports to that end. Another legislation that was passed, the Cleland-Dole Act. It's a long bill. My version is about 2,500 pages. It hits multiple aspects of agencies, but there are some real impacts on VA long-term care. So I'm kind of switching now. So PACT Act was a lot about eligibility. Compact Act really focusing in on mental health, behavioral health, and now the Cleland-Dole Act has some aspects of long-term services and supports. There are aspects of calculating wait times, improving access to care in the community, reporting on those wait times, improving telehealth options for veterans. But there are specific provisions that look at providing stable housing for aging veterans at risk of homelessness. It's requiring VA to develop a long-term care strategy to meet future and current demand for care. And it also allows and provides the authority for VA to pay for care in medical foster homes. That's something that currently before this law could not be done, and it's now authorizing the ability to do that. And it's going to be really fascinating to see how that rolls out. One last piece of legislation, S141, the Elizabeth Dole Home Care Act. It's been introduced. It is the one legislation that has not been signed, but it includes several provisions to expand veteran-directed care, expand PACE partnerships, make sure that coordination of care happens across LTSS, and it also includes some new provisions for homemaker home health aid. So we have a couple links here so that you can track this piece of legislation and what it means. I mentioned expansion of veteran-directed care, and we're actually going to move to that last critical update, and Dan, I'll turn it over to you.
Thank you, Patrick. In January of last year, VA released a press release, which on veteran-directed care, which we'd never done before, and it spoke to the VA's plan to expand veteran-directed care along with our home-based primary care program and our medical foster care program over the next number of years. Last summer and into the fall, there was a rethinking. We have a new undersecretary, and on reflection, he believed that we should be doing our rollout of veteran-directed care, which is currently at 70 medical centers, to all 140 in a more timely manner than a 5-year rollout. And so the governing board, the VHA governing board, approved a plan to roll out veteran-directed care over the next 2 years. That's actually going to be 8 quarters. And how we're going to do this is to develop these sprints over a 12-week, a 1-quarter period of time, 3-month period of time, to walk or sprint with between 10 to 12 medical centers to bring them up to speed and to be ready to admit veterans into veteran-directed at the end of that 12-week period. So we've never done it quite like this before. Obviously, we're used to adding, 2 or 3 new medical centers a year. This is going to be very different. We're really excited about it. We will be, going through our same process of the readiness reviews, also bringing the medical center up to speed on on what their standards and what the program expectations are for their medical center. So this is very big news, and we're really excited by the possibility to do this. So again, thank you for your time and for your support of veterans in this program. It means this, I think Veteran Directed is a favorite program of veterans. I speak to veterans who are in the program and their caregivers. I understand how important it is to their ability to remain safely at home. And the work of the ADNAs that we've been fortunate enough to be involved with has just been excellent. So thank you.
Well, thank you, Pat and Dan. That was very informative. And we have actually a number of questions and they continue to roll in. So we're going to move immediately to the question and answer phase to try to get through as many as we can. The first question is, you just started talking about the accelerated expansion process. When will that start?
We expect to start in July of this year, Merle.
Okay, so that we'd be looking, so if all goes according to plan, that by July of 25, we would have the VDC available everywhere. Am I reading that right?
Everywhere, yes.
Wow.
Yes.
Great. Oh, that takes my breath away. That's terrific. Okay, we've got some kind of more technical questions that folks have been asking. The next one is the authorized rep can be this. The comment was there that the authorized rep can be the primary or secondary caregiver. I was taught that the authorized rep was a non-paid position and as such could not be a paid caregiver.
Dan, do you want me to take that?
Patrick, yeah, why don't you take that, Patrick?
Yeah. Happy to. That is correct. So let me make sure I'm just reading it one more time. So authorized representatives are frequently a caregiver. They cannot be a paid employee for veteran-directed care. In addition, the authorized rep can't be paid to be in that role. That's not something that we want to see. This should be an authorized representative is someone who knows the veteran, has a close relationship, who oftentimes lives with, but is in a situation where they can really try to oversee and manage that care. They know the needs of the veteran. They are able to check in and make sure that workers are going to be there, that they are showing up, that needs are being met. So I think, to be clear, we oftentimes refer to the authorized rep as someone who may be a caregiver, but it's not someone who's paid in that authorized rep role, and it's not someone who's a worker as well.
Great. Thank you. Moving on. You comment that support in-hospital support is permitted. Would that be support permitted only for ventilator-dependent veterans or for all veterans?
Not for certain veterans, Merle, veterans who have real difficulty with communication.
Okay.
Is what we're looking at there. Would not necessarily be veteran ventilator cases. It just happens to be that we dealt with that in the same section of the document.
Right. Okay. And certainly folks who are ventilator dependent often have communication issues, so the two go together.
Yes.
Right. Okay. Moving on. In the VDC component slide, it was stated that veterans opt out of adult day when receiving VDC, but we have veterans who utilize the service that's just paid for out of their VDC budget. Has that changed?
No, it has not. What they're doing is they're opting out of VA enrollment. There would not be a separate VA authorization for Adult Day, they would pay for it. And we're glad to see veterans in veteran-directed utilize Adult Day, but they would pay for that from their own budget. So your current procedure is exactly right.
Okay. Okay. I'm going to read this one as it came in. I'm a little confused about it, but maybe it may make sense for you guys. When timelines for the readiness review conflict with the timelines in the policy manual, which should we follow? Rural area timelines may be different than more metropolitan areas.
Okay, so I'm going to take a stab, and then the person who submitted this can add a little bit more. There, in the readiness review, in the operations manual, there are going to be some outlines on VA requirements. Things like you have to do face-to-face quarterly, right? Monthly contact can be via phone. There are going to be times when that's not possible or feasible. It's not easy to go 2 hours in rural Montana in the middle of winter. In which case, there may be a situation when a VDC provider will do a virtual quarterly visit, but try to do it maybe through video telehealth, where they can see the veteran, see their home, but it may not be face-to-face because it's not possible. So there are situations when you'll need to work with your local medical center. It's not possible to visit this person with the next time period, either because he or she is not available, or it's not we're not able to travel there. So that's a conversation that needs to happen locally. It really should be more of an exception based on an individual circumstance rather than this is our policy and plans. If there's anything that's not feasible or doable for some reason, but it's kind of at your program level, we'd love to hear about that so that we can understand it and think about it. But the requirements are there, and this is more about, is there an individual circumstance where we can't meet those timelines? And that should be discussed with your local VA.
Great. Thank you. That was clear for me, so thanks very much. Moving on to the next one. The VA focus on mental health care, making sure that veterans have access to resources and supports they need. Are there any plans for the VDC case mix tool scoring to be revised and looked at, especially in relation to behaviors, to make sure that under VDC, veterans have the proper support from their caregivers? It's a tough one.
Dan, I'm gonna let you. Do you want to address that first? Do you want me to take the first stab?
We've been thinking a lot about this, both on behaviors also, and which in part is tied to veterans with dementia. We recognize that the current tool is short on this, and we are looking for ways to enhance that tool to be more sensitive to veterans' conditions and the needs of caregivers. That's one of our projects for this next year, it will be addressed. Now, whether it's going to be addressed by the 30th of September of this year, which is the end of our fiscal year, I'm not sure, but it's very much an issue that we know that we need to address, and we've begun to address it.
Right. A couple of quick ones. Will the program, if you're doing expansion across the new VAMCs, will the program still be growing within the existing VAMCs?
Yes, most of our growth in recent years has been not from new programs, but from existing programs that have increased in size, and we expect that to continue. We have provided some special funding to medical centers, existing programs to expand, to add new, parts of the catchment area where they've up to now been unable to serve veterans. So no, that's a very important piece of what we're doing going forward.
Great. And I think kind of a related question, will the timeline and schedule for VAMCs that are being put in the sprints be published? So folks know what their VAMCs coming up?
I don't know if we're going to publish that on our website or not. We did not publish the 5-year rollout, but we'll see. That's a decision. I mean, if it were my decision, yes, we would publish it. But it's not my decision.
Yeah, sure. Back to a more of an internal technical question. One of the VAMCs we work with will not allow the employee to be someone who lives with a veteran. Is that allowable? Is that a restriction that's allowed across the program?
We'll want to deal with that. That's not our national policy, and we will. I'm aware that was an issue at one medical center, and we thought it was resolved, that we had resolved it, but perhaps not, or perhaps this is a different situation we're not familiar with.
Okay. Kind of got a couple seconds. We only got a couple minutes to go, so I want to just kind of check here. Okay, will the VAMCs that have already conducted and passed a readiness review be required to do it again, or can they be prioritized to receive VDC funding as HAP?
Well, medical centers don't go through like a readiness review, but no, all medical centers, if they had a prior interest in veteran directed and for whatever reason decided not to go with it at the time, they will be part of the sprint. Okay.
I'm going to take one for one last question. Is the monthly pay rate for the caregiver still capped? We are currently capped at $20 an hour, but the rate for caregivers in Montana is approximately $25 an hour, and our veterans are paying out of pocket.
Oh gosh, no. There is the cap is gone. We do no longer have a cap.
Oh, okay. That's important information.
Market rates.
Great. Okay, market rates. Okay. And I think really that we're basically out of time. I cannot thank Pat and Dan enough. What, sorry?
Merle, can I just jump in for just 1 second before?
Please do.
This question there, and we're very pleased about this. We will have veteran-directed care programs in the states and in U.S. territories are also scheduled. We're very pleased on January 1 of this year to open the program in the Commonwealth of the Northern Mariana Islands.
Oh, yes.
We'll open in the U.S. Virgin Islands later this year. And,
that's great.
And we will also be covering American Samoa and Guam.
Oh, I did have to skip over that one partly, but that's a personal interest of mine. So I'm really very happy to hear that. That's great, Dan. And once again, but we are out of time now, and I do want to thank both you and Dan and Pat for their time, for the audience for your great questions. I'm sorry we didn't get to all of them. And thank you for your time for attending today. And just a reminder that the slides and the recording will be available on our website. Thank you very much.